This continuing education activity is made possible with the support of Allergen's Greer. In this podcast, Dr. Harold Kim will answer your questions on allergen immunotherapy, or AIT. We chose questions submitted by you, the Saxleaf community, and a survey sent via our newsletter in preparation for this activity. Before we get started, let's go over some technical details. The Canadian Council on Continuing Education in Pharmacy, CEUP, has accredited this program for 0.75 CEUs. After listening to the podcast, you must visit saxleaf.ca and select this podcast in the Activities section of the website in order to complete the quiz. By passing the quiz with a grade of 70% or more, you will obtain your statement of attendance. On this same page, you will find a document in PDF format that summarizes the answers given in this podcast. You can use it to take notes or use it as a quick reference if you want to refer back to a question later on. Learning objectives. Upon completion of this activity, the participant will be able to 1. Summarize how allergen immunotherapy works and when it should be considered in patients. 2. Identify which allergies can be managed by AIT and explain the various treatment regimens available. And 3. Counsel effectively on SCIT, or subcutaneous immunotherapy, and SLIT, sublingual immunotherapy, for patients starting a new AIT regimen. Now, let's get to our questions. Our guest for this podcast is allergist-immunologist Dr. Harold Kim. Dr. Kim is an associate professor at Western University and assistant clinical professor at McMaster University. He is the past president of both the Canadian Society of Allergy and Clinical Immunology and the Canadian Network of Respiratory Care. He currently practices in Kitchener and London, Ontario. Welcome, Dr. Kim.
Thank you.
So our first question for you is, can you summarize what allergen immunotherapy is and explain the difference between SLIT and SCIT? We did a survey with our pharmacists, and they don't seem to be too familiar with AIT, allergen immunotherapy, and even less so with SLIT.
So allergen immunotherapy is really the only treatment that we have in allergy that modifies the underlying immune changes and problems that we have with allergy. So what happens is that when you have allergy, there's a problem with immune regulation, and some of the cells that are involved are the regulatory T cells. And so what we do with immunotherapy through different mechanisms, including desensitization, modulation of the T cells and B cells, and also changing the allergy cells, including the eosinophils, basophils, and mast cells. Through those different mechanisms, we can actually modify the abnormal T cell response, the regulatory T cell response, and change that so that we suppress the immune regulation in terms of over stimulating the allergy response and down-regulating it through those mechanisms that we discussed there. So with allergen immunotherapy, there's two different ways that we can administer it. The first way to administer it is sublingually. So we actually put allergen under the tongue. And with that approach, we can actually treat allergic rhinitis and conjunctivitis. And we have 4 different allergens available that we can treat now. We can treat grass pollen allergy, tree pollen allergy, ragweed pollen allergy, and house dust mite allergy. And we have those 4 allergens in Canada. And about 80% of patients will have clinical improvement, significant clinical improvement, when we treat with sublingual immunotherapy using 1 or more of those allergens. Now, over the longer term, for actually over 100 years, we've actually had subcutaneous immunotherapy available. And subcutaneous immunotherapy is where we give the treatment subcutaneously with injections. And we have more allergens available with that approach to treatment. But the benefits are that approach to treatment may be a bit more effective than sublingual immunotherapy, and it has a longer history. The drawbacks are that you have to come into our clinics or to your family doctor's clinic to get the injections regularly. So there is some discomfort with shots. And also there may be an increased risk of anaphylaxis because those injections are given more directly and can lead to more significant systemic reactions with the injections. So it has some benefits and drawbacks, both approaches to immunotherapy.
Okay, excellent. So thank you for that overview to start with. Our next question comes from Rania Sudi from Edmonton, and she asked, what type of allergens is AIT suitable for?
So with subcutaneous immunotherapy, we have treated allergens including house dust mite, cats, alternaria, which is a mold, ragweed, grass, and birch pollen. So those allergens have been studied well. We sometimes can actually give some other allergens which are non-standardized, but generally we try to stick with the allergens that have been studied well. With sublingual immunotherapy, we have two different versions of grass sublingual immunotherapy. So the first one that was available is one called Oral Air, and that's a mix of 5 grass pollens. And with that sublingual treatment, it's indicated from age 5 to 50. And we give the first dose in our clinic, and the first dose is 100 IR. And then the patient takes the second dose at home, which is 200 IR. And then on the third day, they stay on 300, they start 300 IR, and then they stay on that dose every day. So typically we start it about 12 weeks before the grass season, which will be in much of Canada in January or February. And then you stay on that dose daily until the end of grass season, which typically would be at the end of July. So that's grass allergen number 1 that's available sublingually. There's also a product called Grass Tech, which is Timothy grass. And with that allergen, it's indicated from age 5 to 65. And that one we start with a dose of 2,800 units. And we start that at the full dose in our clinic. And then they take that every day until the end of grass season. So about, again, 12 weeks before the season until the end of the season. House dust mite sublingual immunotherapy is called Acarizax. And that one is indicated from age 18 to 65. And it's 12 units that we give. And again, we started at the full dose. And then they take that every day all year round. We usually give that one for 3 years and sometimes up to 5 years. And again, because dust mite is a year-round allergen, we take it all year round. The next one is Ragwitech for ragweed. And ragweed is a problem, especially in southern Ontario, southern Quebec, the Maritimes a bit. And that allergen is started, so ragweed typically starts in terms of pollinating mid-August. So we start it in mid-May usually with the Ragwitech tablet. And again, the dosing is 12 units. And we give the first dose in our clinic in mid-May, and then the patient will stay on that every day until first frost when ragweed season stops. And then the last allergen that we've had available from as a sublingual product is a birch pollen tablet called Atulatech. And that one we start about 12 weeks before the season. So in Ontario, for example, we would typically start that in December. In British Columbia, where the birch pollen season would be earlier, they would start that 12 weeks before the season, which may be in November or even earlier. So you start that with the standard dose of 12 units, and then you take that dose every day until birch pollen season is completed. And that can vary depending on where you are in Canada. In Ontario, for example, we would typically keep that going until probably early June. And then you stop it. So the seasonal treatments we would treat for about 3 years. And then after that, we typically would stop the patient from treatment to see if they have a prolonged protective effect after the 3 years. With grass pollen, we know that if you take it with Grass Tech, if you take it all year round for 3 years, then you may have a protective effect after stopping it. With Oral Air, if you take it pre-seasonally and seasonally for 3 years, then you may have a prolonged protective effect. So again, 3 years of treatment is standard.
Okay, excellent. So that gives us a good overview of the different products available. Now our next question is from Sue from Toronto, who wants to know how fast is the effect?
So with the sublingual tablets, as they are indicated about 12 weeks before the season, they usually work for that season. So they start working within a few months. So which is great. With the subcutaneous injections, typically it takes 6 to 12 months for those treatments to become effective. So we really want patients to be on it for at least a year before we say that it's effective or not. So um, a few months for the sublingual tablets and 6 to 12 months for the subcutaneous injections.
Okay, I'll have maybe a little follow-up question. Is there a specific reason why the subcutaneous takes longer to act?
It's a complicated question in terms of what the right answer is, but I think probably the reason why the sublingual tablets work more rapidly is because we really give the full dose right away. And
Okay.
so the patient's exposed to that full dose immediately. With subcutaneous injections, because of the risk of reactions, we start at very, very low doses. And over a period of about 6 months, it takes to get up to the full dose. So I think it probably is a dose issue.
Okay, great. Our next question is was submitted anonymously from someone that would like to know more about AIT in children.
So with subcutaneous immunotherapy, historically we've used the age of 6 as a minimum age, but pragmatically, because it involves needles, we usually don't start subcutaneous immunotherapy until a child is about 8 or 9, and I think that's a reasonable age to consider starting. With the sublingual treatment or treatments, the grass allergens are officially indicated 5 and up. So of course we can use them at that age and older. The other allergens officially are not indicated until the adult years. So, but I will say that some of the the newer allergens will have a lower age indication. Of course, with sublingual treatment, we think that it's kind of more suited for kids because there's no needles involved. And I think over time we will be using the sublingual treatments more often in kids. Another important point is that there is some data from older studies from Europe suggesting that if we give children subcutaneous immunotherapy to birch and grass pollen between the ages of about 7 and 10, and then we go back and look at those kids as adults, the subcutaneous injections might actually prevent some of those kids from developing asthma later. So there may be like a secondary prevention of asthma for those kids if we treat them young with subcutaneous injections.
Okay, so that's a very important effect to
Yeah.
consider. Absolutely. Okay, very interesting. Now let's go on to our next question. Janice Harvey from Courtney asks, how do you determine initial dosing and how does the patient know when or how to adjust the dose?
So with the sublingual products, it's fairly straightforward because the dosing is standard and standardized, and really the tablets come in one dose only. So as mentioned, with the oral air grass product, we start with 100 IR, and then the second day they take 200 IR, and then they take 300 IR per day. With the other allergens, so with grass tack, with Atulatac, with Acarizax, and with Raguatac, all of those are started at the same dose, standard dose tablet, and then they take that dose every day, so it's easy. With subcutaneous injections, what we've done as a recommendation from the Canadian Allergy Society is to try to standardize things to try to make it more consistent and hopefully safer. We have a building or a dosing protocol that we have, and we recommend that allergists follow that protocol or one that's very similar, so that weekly the patients get the dosing build up until they're up to the highest dose, and then that interval is gradually increased to monthly. So that dosing is a bit trickier. The dosing is pretty recommended in a standardized fashion as much as possible. If patients miss a dose or when they get a new set of serum that has to be ordered yearly, then we recommend, standard cutback so that again, hopefully the injections can be given in a safer manner.
Okay, and is this protocol available somewhere where pharmacists can view it as well? Is it online?
Yes, so different allergists will use different protocols based on what they feel is reasonable, and also what their labs recommend. But if you go to our website, the Canadian Society of Allergy website, csaci.ca, there will be a link to our allergen immunotherapy manual, and you can download that PDF. And that PDF, at the very end of the manual, has our recommended dosing schedule.
Okay, great. And it is also referenced in the PDF summary document that listeners of this podcast will have access to. If they would like to have access, they can also check out the references in the summary document.
Great.
So we'll move on to our next question. How long should the therapy last to be most effective in the long term? The question comes from Joanne Molnar from Ottawa.
Yeah, so one of the advantages of immunotherapy over routine medical therapy is that immunotherapy is a disease-modifying treatment. And we have that data from good studies with subcutaneous and sublingual treatment. And the studies have been mostly done with grass pollen allergy. But we believe that 3 to 5 years of treatment with sublingual or subcutaneous injections will lead to disease modification. Officially, that's only indicated with sublingual therapy, or I wouldn't say indicated. Officially, that's only been studied properly with grass pollen. With subcutaneous injections, the best studies have also been done with grass pollen. And so 3 years of treatment probably leads to prolonged protection after stopping at 3 years.
Okay, excellent. Now, on to our next question. If you start SCIT or SLIT, but don't finish the course, do your allergies become worse?
So we actually have not looked at that in terms of randomized controlled data, but we do not believe that the symptoms will actually be worse than you were before you started. But we do believe that your symptoms would probably go back to baseline. So we don't think it would actually be a worsening or an aggravator of symptoms, but it won't help symptoms if you're not on it long enough.
Okay, great. Just to go back, we have some summary tables.
So I think importantly with regards to subcutaneous injections that so patients have to be on the weekly injections for about 4 to 6 months to build up to the maintenance dose. And then most of us would recommend receiving that maintenance dosing between every 2 and 4 weeks. Most of us try to give the maintenance dosing once every 4 weeks. There is also pre-seasonal subcutaneous immunotherapy where you can give injections weekly for about 9 weeks. And those allergens are linked with aluminum. And when you have alum-linked allergen, then the immunotherapy is absorbed more slowly. So it's a bit safer to build up more rapidly to high dose. So again, those doses are given once a week for about 9 weeks before the season. And then you can have an effect for that specific pollen that you're treating. With sublingual immunotherapy, the treatment effect, again, takes about 2 to 3 months. So we recommend starting about 12 weeks before the season and staying on that treatment for the 12 weeks before the season and then through till the end of the season. With dust mite, of course, because it's a year-round allergen, you can start that treatment any time of the year and stay on the dust mite tablets all year round for 3 to 5 years. Another important point, of course, is that most of our patients in Canada have multiple allergens as a cause of symptoms. So with subcutaneous injections, we can have more than one allergen injected at the same time. But with sublingual tablets, the treatments come in as separate allergens for that separate treatment. So you have a dust mite tablet and a grass tablet, a ragweed tablet, and a birch tablet. So if a patient is allergic to more than one allergen, what many of us will do is give 2 allergens together. So typically what we'll do, for example, if let's say a patient's allergic to grass and ragweed, we would start them on the grass tablet in January, which they would take until the end of July. But they would also be started on the ragweed tablet in May, and then they would take that until about October. So for a period of a few months, they'll be on both tablets together. And so typically what we would do is we'd have them on grass, then they come into the office for ragweed, and we would have them take one in the morning, one in the evening for a few weeks. And then if they're tolerating the tablets together and they're safe, then they would take them kind of 5 or 10 minutes apart at one time in the day, either the morning or evening typically. And we feel that's a safe approach. So you can be on multiple allergens at the same time if needed.
Our next question comes from Joanna Ong from Fonthill, who would like to know what are the long-term side effects of AIT, our allergen immunotherapy.
So with sublingual immunotherapy, the main long-term side effects that we are concerned about are eosinophilic esophagitis. So not very often, rarely, patients can actually get allergy of the esophagus. So we believe that happens because the patient is swallowing a tiny bit of the allergen and it's coating the esophagus and causing eosinophilic inflammation in the esophagus. That happens very infrequently. But there are more common immediate side effects that probably do not lead to long-term problems. About 10 to 60% of patients will get local irritation or itchiness in the mouth or ears, and typically that's short-lived, so that will happen for 20 or 30 minutes on the first dose, and then for a few doses after that, and then it will go away. Some people, about 5 to 20% of patients, will feel almost a swelling feeling in the mouth, again, usually self-limited. And up to 70% of patients can get throat irritation. Again, it's usually self-limited and goes away. If those symptoms are severe, then we'll stop. But usually, again, those symptoms are tolerated and go away in the first few days. Rarely, there can be severe side effects such as anaphylaxis. There are case reports only with that. But some patients, about 2 to 14%, will have nausea, and up to about 10% will have mild abdominal symptoms. So again, if those symptoms are bothersome enough, we'll stop. But usually they're mild enough that the patients can keep on it and the symptoms will gradually resolve. Now, with subcutaneous immunotherapy, about 1 in 20 patients will have systemic allergic reactions where they will need epinephrine at some point. There are actually reports of death from subcutaneous immunotherapy, and that is why every patient that gets subcutaneous injections should and must wait in the doctor's office for half an hour after the injection. And if there are severe symptoms, then epinephrine's used for treatment, and they would be taken to the emergency department. Usually, though, most patients will tolerate the updosing and maintenance therapy, and usually, the 3 to 5 years of treatment is well tolerated. And aside from the anaphylaxis, we really do not have any definite long-term side effects from subcutaneous immunotherapy. A more common side effect, though, are that a significant number of patients will have local reactions at the injection site. And so we treat those injection site reactions with antihistamines and often with ice packs in the office. And usually over time, those local symptoms will gradually resolve.
Okay, and if we go back to the sublingual immunotherapy, is there anything we can suggest for the mild local mouth reactions, for example?
Yeah, typically what we recommend, if a patient has significant local symptoms, we would recommend a non-sedating antihistamine before taking that dose each day. And again, usually over about 4 or 5 days, those symptoms resolve. Some of us, because the local side effects are frequent enough, some of us will actually recommend that a patient just prophylactically takes a non-sedating antihistamine before the sublingual tablets, usually an hour before. And that often will help prevent any symptoms from happening at all, because those local side effects are fairly common.
Okay, thank you for that answer. Okay, so we'll move on to a question about COVID. What effects has COVID, the pandemic, had on AIT? What are the effects of AIT on a patient that has COVID? So they're two very different questions. So maybe we can start with what effect has COVID had on AIT?
So with COVID, of course, that has limited our face-to-face interaction with patients. So What we recommended actually at the Canadian Society of Allergy is last year we suggested if a patient had already been on sublingual immunotherapy and tolerated it well, then typically we would have a patient come into our clinic to start the second year of treatment as well. But if they were symptom or, there's no severe side effects and they tolerated the first year, then we suggested they could start it at home. And so we did that last year and we've done it this year as well. And as far as I'm aware, that's worked quite well with patients. With subcutaneous injections, many of us actually stopped patients from getting the shots because we really didn't know what was going to happen with the pandemic, or many of us maintained patients on a maintenance dose, and now we're just starting to build them up again. So that's been the impact of COVID on AIT, I believe, in Canada.
Okay, great. And so things are they starting to move back a little bit? We're recording this in June 2021. Are things starting to go back to how they were pre-pandemic?
Yes, so I think most of us now, as this third wave in much of Canada is waning and hopefully will resolve, many of us now are starting to have our patients come into clinics again for build-up dosing. So that has started again recently. With the sublingual tablets, again, I think many of us are still having patients restart them at home. But for any of the new patients, we do have them take the first tablets here in the clinics. Something that some of our colleagues have done kind of as a real novelty, they've actually had drive-through sublingual clinics where a patient will get their tablet in their car and hang around in their car close to the clinic for half an hour after. So that's been a novel approach with some patients. So there have been some advances in terms of how we deal with patients with immunotherapy.
That's very interesting to hear about the drive-through immunotherapy. So, okay, so yeah, our other question was about are there effects of AIT on patients that would have COVID?
So great question. So fortunately, most of the allergy treatments that we give really do not have an impact on COVID infection or COVID vaccination. So if a patient is on sublingual or subcutaneous immunotherapy, we really do not believe that there's an impact on the virus or the infection or the vaccination. Just so that we don't confuse reactions to the COVID vaccines or reactions to the immunotherapy, we generally would say that patients should not take either subcutaneous injections the day of the vaccination or hold their dose of the sublingual immunotherapy on the day of the vaccination. But aside from that, there should be no real interaction or negative effect of immunotherapy on COVID infection. Now, one benefit would be that if patients are treated adequately for their allergies, then you would have less allergy symptoms, hopefully, and then less confusion with COVID. I've heard from a number of patients, especially kids, that they're often sent home from school when they have allergy symptoms because the school is concerned that they may have COVID. So that may be a positive effect of being on immunotherapy. If you have less allergy, then you'll be confused less with having COVID.
Yes, we've heard that a lot. Okay, great, thank you. So our next question is also submitted anonymously. What are the patient counseling points? What are the main things you tell patients?
So typically with regards to efficacy, both for sublingual and subcutaneous immunotherapy, I tell patients that there's about a 70 to 80% chance that they will be significantly better on subcutaneous or sublingual immunotherapy. Now, importantly, of course, we also counsel with regards to safety. So for sublingual immunotherapy, we typically tell patients that there's about a 40 to 50% chance of having local side effects in the mouth and throat. And so we tell people to expect that. They can treat with antihistamines beforehand if they like. There's a very small risk of eosinophilic esophagitis. So we ask patients not to eat or drink for about 5 minutes after taking the sublingual tablet. If they have symptoms of dysphagia or significant acid reflux, we want them to contact us. If a patient has had a dental procedure or a cut in the mouth where there's local trauma or bleeding, then we would say that they should not take the sublingual tablet until the mouth heals. And then in terms of subcutaneous immunotherapy, the main things we warn people about are the small risk of significant anaphylactic reactions and the very small risk of potentially of death from subcutaneous injections. So we absolutely have them, they should wait for 30 minutes in our offices after they receive the injections. And if they have anaphylaxis, then they should be treated with epinephrine and be transferred to the hospital if it's severe enough. Also, very importantly, and we see this often enough, is that if a patient is on a beta blocker, they should not receive subcutaneous or sublingual immunotherapy because beta blockers may increase the risk of anaphylactic reactions and may make treating anaphylactic reactions more difficult. And there's also some evidence with ACE inhibitors as well. So typically, we would suggest either coming off the ACE inhibitor or at least holding it for the day that they're taking or getting the subcutaneous injection. With beta blockers, we typically recommend that a patient should stop a beta blocker or we would not put them on subcutaneous or sublingual immunotherapy.
Okay, I'll have a little follow-up question. In your practice, would you have someone stop beta blockers that are not given orally, for example, in eye drop form for glaucoma? Is that a contraindication to you?
Yes, I mean, we really don't think about beta blocker eye drops as being a big issue, but they are absorbed systemically. They can worsen asthma, and I would recommend that those eye drops be stopped as well before subcutaneous or sublingual immunotherapy be given.
Okay, thanks. The other question I would have is concerning epinephrine. Do we give an auto-injector to all patients that are prescribed SLID? Maybe first off, do you prescribe it? And then the follow-up question is, if we don't get a prescription for that, when patients are prescribed SLID, should we be providing it?
So I do not prescribe an epinephrine auto-injector for all patients on sublingual immunotherapy. I do offer it to patients if they're concerned about it. I don't think it's a wrong thing to do. I believe in the US still, they recommend having an epinephrine auto-injector when SLID is prescribed. But in Canada, I think most allergists do not prescribe an auto-injector when patients are on SLID.
Okay, thanks for that. Then our next question, and actually our last question, is: do you have any references to suggest to pharmacists who want to learn more about allergen immunotherapy? We've talked a bit, and I really appreciate you providing your clinical experience. It gives us a lot, just for a much better understanding for something that's, I feel from the survey we sent out to our members, not all that well known. So if we want to read more, where would you lead us?
So there have been some good documents put together over the last few years that are, I think, great references for pharmacists. So the first document is the Immunotherapy Manual, and that's the Canadian Society of Allergy and Clinical Immunology Manual. So if you go to csaci.ca then and follow the links, you will be able to download the PDF for that manual. We put that together about 4 years ago, and we will be updating it over the next year or so. Then there's a reference that we put together and published last year in 2020, and the lead author, his name is Calderon, and that paper is called The Clinical Practice of Allergen Immunotherapy for Allergic Rhinoconjunctivitis and Asthma, an Expert Panel Report. And it's quite an extensive review on kind of the state of immunotherapy right now, and looks at how we do things now and how we should maybe be doing things in the future. and that's in the Journal of Allergy and Clinical Immunology in Practice 2020. There's also some specific documents on one document on tree pollen immunotherapy from Wurtzen, Wurtzen, that's published in Clinical Experimental Allergy, which is the main British journal, and that was published in 2021. And then there's a grass sublingual immunotherapy paper published by Dahl, D-A-H-L, and that's published in Allergy Asthma Proceedings in 2016. And finally, two papers on dust mite immunotherapy. One is guidelines on allergy immunotherapy on house dust mite-driven allergic asthma that was published in Allergy in 2019, and the lead author is Agache, A-G-A-C-H-E. And then there's another paper on sublingual immunotherapy for house dust mite-induced allergic rhinitis that was in the Medical Letters for Drug Therapy in 2018. So I think we can provide a list of those references for you that are listening, and I think all of those papers are very good reviews.
Great. Thank you so much. Actually, okay, before we officially close, is there anything else that you feel we didn't cover, something that you feel pharmacists should know?
Yeah, I mean, I think even before we get into allergen immunotherapy, I think most patients can be controlled with allergen avoidance and medical therapy. And, the standard treatments that we really try to encourage patients to use are the non-sedating antihistamines. We really don't want patients taking the older sedating drugs because there are many studies done suggesting that those drugs are more impairing than being legally drunk. So we really discourage that. And in Canada, those drugs are still overused. And then we have the nasal steroid sprays, which I know all of you know are very effective and safe, and those products should be used as well. So if those medications are not effective, then we should be thinking about sublingual and subcutaneous immunotherapy. And I would encourage you as pharmacists to have your patients referred for testing and prescribing those treatments, because as we've discussed, those are truly disease-modifying treatments, and there are studies to show that there really are immune changes that happen when we prescribe and use those treatments. So I would encourage that your patients be referred to us in terms of getting those treatments prescribed. We now have treatments that are effective and typically and routinely used and usually very safe for patients. So we would encourage them, and I would suggest that we as allergists and pharmacists, I think we should be communicating more in terms of interaction, because allergy is so common, and it's an area that I think is growing and advancing, and I think communication is really important.
Absolutely. I like that last sentiment. I definitely agree. And I appreciate you putting that all back into context at the end right now. So thank you very much, Dr. Kim, for participating in this podcast. And I really hope our listeners will find this useful for their practice. So thank you very much.
Thank you.
For our listeners, now that you have listened to the podcast, you can go to sacsleaf.ca and select this podcast in the activities section of the website in order to complete the quiz, which will allow you to get your statement of attendance if you get a grade of 70% or more. Then, we ask you to take a few minutes to complete the activity evaluation, which you will find on the same page. Your comments are always important to us. Lastly, to stay informed of our latest continuing education activities, make sure to sign up for the SacsLeaf newsletter. Thanks for listening.